How you guys doing?
Doing good.
Okay, let's get back to work. So we left off at bone remodeling. So we're talking about kind of some bone physiology pieces. And so um, still continue our discussion of bone remodeling. So we just got done mentioning remodeling and basically kind of how this works. Um, and so ultimately what you have are kind of basically groups of migrating cells called basic multicellular units, BMUs. And so these are just kind of like a temporary outpost or a collection, a garrison, if you will, of osteoclasts and osteoblasts. And so the first thing that you do with bone remodeling is you have to remove the old bony matrix, and then that's the osteoclast job, right? So they tear it apart, and then the osteoblasts are going to come in behind it, and they're going to basically lay down and replace it with new bony matrix. So of course, in this time around, instead of laying it down as woven bone, you're going to be laying it down as lamellar bone. And so these little groups, if you will, or kind of traveling troops of cells will kind of hang around for about 6 months or so. And so this is just kind of like your natural turnover, right? So this, what we're talking about here, these BMUs, this is kind of like your normal turnover and replacement. So you're constantly kind of turning it over, turning your matrix over, replacing it, refreshing it. And so this is kind of what's happening sort of in the background. So we're not talking about like, when you've broken your arm and you have to basically make new material in order to reconstruct your broken arm, your broken bone. This is kind of like just normal skeletal maintenance, the normal turnover and replacement. And so the activities of the BMU will basically mean that your skeleton is pretty much turned over with new material roughly every 10 years or so. So the skeleton you have now was not the one that you originally started with. You're basically wearing a new set of clothes, skeletal clothes, so to speak, and that's been turned over a few times. So throughout our adult life. So depending on how old we live. And so ultimately, what we do is we essentially, when we're laying this down, we'll come in and replace the new bone, and we're going to be making new osteons in the compact bone. And so the way that we make new osteons, when we kind of go in there, obviously it's kind of like one of those things where you're sort of like doing road work, right? So it's kind of like, you have to figure out how to fix one lane, but you have to keep the other lanes open and functional. That's like you can't just shut down like a major road. You've got to figure out some sort of directing of traffic. You have some strategy to sort of keep traffic flowing. So it's like you have to be functional in the middle of replacing all this material. And that's kind of what's happening here when you're doing this. So like, for instance, when you're talking about making new osteons, you kind of have to make it within the context of not compromising the integrity of the existing osteons while you're basically forming new ones. And so the way that you do that is essentially the same basic pattern, right? So you basically send in the osteoclasts who are going to come in there, and they're going to come in from the blood into the central canal, and they're going to move into the osteons itself, and they're going to start removing some of that lamella. And then, of course, osteoblasts will then replace that bone quickly. So you don't just basically remove your bony matrix and just leave it removed, right? So you lay down new bony matrix almost immediately right after it. So it should be like a one-to-one relationship, right? So for every unit of lamella removed, you replace it immediately with a new unit of fresh bone. And what this means then is that the osteoclasts that are removing bone, the osteoblasts are replacing it. So this means that there's an inherent balance between the osteoclastic activity and the osteoblastic activity. Now, here's the problem with that. We'll talk a little bit more at the end of the chapter. basically through most of your life. The reason why your bones maintain their integrity and their density is because the activities of the osteoclast are for the most part in balance with the osteoblast. So essentially they're going to be in lockstep. So you don't really experience any net bone addition. You don't really experience any net bone loss because they're in balance. Now, as you get older, what happens is the osteoblastic activities begin to slip in their efficiency and their ability to keep up with the osteoclast. And so the older we get, the osteoclasts start to kind of, things start to, this homeostasis tilts toward the osteoclastic activity, which means that you slowly start to experience a greater and greater rate of bone loss relative to bone replacement. And this ultimately leads to weaker bones and less bone density as we get older. This is just a general thing that happens during aging. This isn't osteoporosis, or osteoporosis is oftentimes triggered by other things. This is something that would happen in the background with or without those triggers being sometimes hormonal triggers, and things like that. So you just through aging, there's just this natural sense of atrophy of the osteoblastic activities that will slowly kind of start slipping and won't be able to keep up with the osteoclastic activities. Now, it's a very slow slip, right? So it's not like you're just going to wake up one morning when you're 50 and you're going to have just, all these bones turning into dust on you. It's a slow kind of slippery slope as you get older and older. And so ultimately, when you take a look then at bone development, whether it's osteoblastic or osteoclastic activity, this balance, a couple of things can tip this actually in the favor of osteoblastic or deposition activities. So for instance, if you increase the stress that's on your bone itself, then that's going to trigger your bones to increase in strength. And the way that you do this is by triggering remodeling. Normally, also, what you're really triggering there is the osteoblastic deposition of bone. So you're going to deposit more bony material, and so you're going to add additional bone, and this is going to thicken up your trabecula, and it's going to remold your trabecula to align with those lines of stress, so that you meet that stress force head on, and not side on. So typically, if you're a trabeculum, you got this little column of bone, you want to meet your stress levels head on like this. You don't want to be meeting your stress levels like in a lateral kind of a position. That's not the way you want it to be. So what you'll do is you'll basically deconstruct this if your stress lines change, and then you'll reform your trabecula to basically line up with your stress lines. And so what this does then is your stress increases your bone deposition to match the stress on your bone. And if you reduce the amount of stress, for instance, lack of use, then what happens is that's going to tilt this homeostasis toward osteoclastic activity compared to osteoblastic activity. This is one of the reasons why your body is designed to be used. So what you want to do is you want to basically get out there and use your body, because your body builds itself and it strengthens itself based on all of the use cues that you give it as you're using your body. So a sedentary lifestyle is typically a lifestyle of physiological and anatomical atrophy. And so that's one of the reasons why you want to get up and move around, use your body. You don't have to work it out. You have to blow out muscles and stuff like that, but just stay active, right? So when we take a look at remodeling on the long bone, so here we can see the different stress angles. For instance, so taking a look at the femur. So typically the femur is going to be experiencing these compressive forces, which are basically pushing down from your hip girdle, going straight down through your legs. So this is basically a mechanical type of stress, your weight essentially. And generally speaking, what's going to happen is here you have your force lines, right? So that's what's happening here. So when you're kind of lifting more and more weight, ultimately what's going to happen is your body, your bones are going to respond to this increase in stress. So it's going to increase your osteoblastic activity and lay down new bony tissue, right? So that's basically what's going to start happening. So here you can see the increase in stress. It typically is going to follow stress lines that go down the medial side of the femur. And so as a result, what's going to happen is, since the stress lines are going to the medial side, what happens is it creates this imbalance in stress, causing the femur to bow outward. Now, ultimately, what's going to happen is you're going to respond, you're going to sort of change essentially the nature of your bone thickness. And so what's going to happen is you're going to take away bone from the area that has little stress. So this is the lateral side. You're going to remove bone from there because there's not a lot of stress over there. And you're going to add that bony matrix and thicken up the compact bone on the medial side because that's experiencing greater stress. So ultimately, the collar of the bone, if you take a look at it, is going to be thicker on the medial side where you're experiencing the most stress. So this is one thing that's actually true about bones and the way that your bones work. Remember, this is just normal adaptive response of your bones. A lot of people don't realize this, but your bones are actually very dynamic. The amount of weight that you're pushing on your bone will cause your bones to remodel and to sort of beef up those areas that are under more stress so that they can handle that excess load. Now, when you stop bodybuilding or you stop weightlifting, which is the example that we're using here, then what's going to happen is you're going to relieve that stress, and then it's going to recalibrate and sort of it's going to rebalance itself. Okay. So now let's go ahead and break some bones, shall we? So the first thing we're going to be doing is when we take a look at bone fracture, when we take a look at bone healing, right? So ultimately, we can classify fractures based on a couple of things. First of all, by the mechanism of the fracture, for instance, how it was fractured, whether it's traumatic fracture from injury, if it's a disease fracture, like a pathological fracture, or something of that nature. It can be based on whether or not there's soft tissue damage, so closed, for instance, versus open. So that would be a dramatic fracture, or displacement versus non-displacement. So whether or not it's actually grossly displaced in terms of its original positioning. It can also, we oftentimes will look at it in terms of fracture pattern. So what is the geometry of the force that created the fracture? For instance, is it a linear a spiral fracture, an avulsion, a stress fracture, a compression fracture? So these are different types of fracture patterns that we see depending on how the stress is acting on the bone and the nature of what happens to that particular bone. We can also categorize this by the number of fragments. For instance, if it's an incomplete fracture or a complete fracture or a comminuted fracture. So this is just basically how many fragments of the fracture bone there are, or age specific, right? So for instance, green stick would be fracture. One type of age-related fracture. Epiphyseal fractures would be associated with the epiphyseal line fracture. So there's different like age-related types of age fractures. So this is kind of how some of the bone fractures look. So we have a couple of different, a linear fracture, for instance, would be basically a fracture that kind of goes linearly down the length of a bone itself, right? So a complete means it's basically broken clean through, versus an incomplete means it's not completely broken through. Kind of the same way you would do if you're breaking a branch. In terms of fragmentation, you can see the comminuted is basically you got a bunch of fragments that are kind of it's kind of like a kind of a blown out fracture. So you got little chunks and shards in there. Oftentimes this will require surgery to get those fragments kind of in line to hopefully get those to start healing up. So sometimes that'll require some surgery. An impacted fracture is associated with stress that's basically creating this kind of grinding effect. So when two bones kind of impact against each other, that's going to be an impacted type of a fracture. A spiral fracture is one that basically kind of has a bit of a twist to it. And then an oblique fracture is just basically an angular fracture. Remember, oblique basically means diagonal. So those are different types of fracture patterns that we see. Now, and there's like different names for these, right? So you have like Colles fractures and things of that nature. And so if you get into orthopedics, you'll learn a lot more about fracture patterns and fracture types and things of that nature. So there's a a lot more to go into that. And if you get into orthopedics, you'll learn a lot more about those different types of fracture patterns and then how those fracture patterns vary as you get, say, for instance, at a long bone versus close to a joint or something of that nature. So now we want to take a look at bone repair. Okay, so what do you do then? What's the process of actually how your body repairs after a break? So it comes in a couple of different steps. First of all, the first step after a bone break is to form a hematoma, right? So basically, a hematoma is simply just a large blood mass. Because when you break a bone, remember, bones are very vascular. There's lots of blood vessels going through the medullary cavity. And so when you break a bone, you're not just potentially, depending on the nature of the fracture, you're not just damaging soft tissue and lacerating blood vessels in your soft tissues, but you're also disrupting the blood vessels that are in the medullary cavity themselves. So it's a very bloody type of an injury. And so as a result, you get this mass of blood that's coming from these blood vessels, but it's usually confined within the bone itself. So what you're doing here is you're basically trying to fill the gap, trying to fill the break. Now, remember we said before that like with woven bone, right? So woven bone is the cheapest, dirtiest stuff you can get. It's super cheap, and it's just like your stopgap, right? Just to buy you some time so that you can actually put in some better stuff. And that's the way you do bone repair. So what you first try to do is you try to fill the break with the cheapest, quickest fix possible. And so basically, since you have all this blood, and blood is connective tissue, remember, this is a type of connective tissue, then what you're doing is you're basically using this connective tissue and the platelets in your connective tissue to basically form a clot. You're coagulating that blood in order to sort of plug the hole. So it helps to plug the breach in the bone with something, right? So coagulated blood, although it's not structurally all that impressive, it's at least something. And so what this does basically is it helps you to stop the bleeding. And if there's fragments, it could potentially help to bind some of those fragments and keep them in somewhat, relatively close region so that you can use those fragments to help fill out the bony matrix, to replace the bony matrix with. If you lose those fragments and they go floating off somewhere, then you're kind of screwed, right? So that's one of the jobs of the hematoma: stop the bleeding and try to plug that hole as best you can. Now the problem is, once this happens, because you have blood spewing all over the place, that means it's not getting to those osteocytes, and that means then that the bone tissue dies, and so it has to be replaced. So the next step that happens is what's called callus formation. And generally speaking, you have an internal and external callus. So basically, a callus is essentially just a big mass of tissue that forms at the fracture site. It replaces the hematoma plug, but its goal is to connect the broken ends of the bone. Now, generally speaking, you kind of see in callus formation, in some textbooks, they organize the callus formation as cartilaginous callus versus bony callus. In Sealy, they do internal versus external. But the idea here is oftentimes what you do is you recapitulate endochondral ossification. What do I mean by that? So what I mean is that the first callus you lay down is typically cartilage. It's cartilaginous because that is the next easiest thing, right? So cartilage, laying down cartilage is an easy thing to do because you still have your periosteum, right? And in your periosteum, you have these osteochondral progenitor cells. And what these guys will start to do is they will start to differentiate into chondroblasts. And so what they'll do is they'll produce cartilage within all of that sort of gummed up hematoma with collagen, and so they'll start laying down collagen and so forth. So basically, they create a cartilaginous plug. That's your first callus. Now, while this is happening, you have macrophages at the site that are coming in, and through phagocytosis, they're gobbling up the debris and they're devouring that and they're getting rid of that. Osteoclasts are also coming to the site, and they're basically breaking down that dead bony tissue, not just the dead tissue, but the dead bony tissue. The stuff that's already dead, you can't do anything with it. It's just gobble up that matrix and let's reuse it somewhere. So that's your osteoclastic activity. Then at the same time, your fibroblasts, remember these guys are going to be coming in and they're going to be making collagen and granulation tissue, which is a type of connective tissue. It's a dense connective tissue. And so what's happening is three different things. So you have macrophages that are cleaning up the debris, osteoclasts that are breaking down the bony matrix that's dead, and then fibroblasts, which are laying down new collagen and connective tissue in the form of granulation tissue in that hematoma structure. This is all able to do this because in the hematoma, which is a soft little plug, blood vessels are able to grow into the clot in the hematoma because it's soft. And because it's able to grow into the clot, it's able to deliver macrophages, osteoclasts, and fibroblasts. Well, the osteoclasts are coming from the osteochondral progenitor cells, but there's certainly fibroblasts and macrophages. So then once you get the combination of the macrophage activity, the osteoclastic activity, the fibroblast activity, then the osteochondral progenitor cells, pretty much at the same time as what's actually happening, are basically differentiating the chondroblasts, which then start to produce this cartilage within that collagenous matrix that's being laid down by the fibroblasts. And then the next step after that is the osteoblasts from the periosteal liner will invade, and then they'll lay down new bone, replacing the cartilage. Sound familiar? It should. It's the same basic pattern that we did when we did endochondral ossification. We were laying down or replacing cartilage with bony matrix. Now, the external collar ultimately is going to be associated with your periosteal osteochondral progenitor cells, which will be differentiating into osteoblasts on the outside. And also chondroblasts. So you're doing the same thing on the outside as sort of on the inside. And then you start to create this bone cartilage collar that kind of stabilizes those two pieces. So you kind of have a cleanup going on the inside with your cartilage being laid down and then replaced by bony matrix. And you have the cartilage being laid down and replaced by bony matrix on the outside of the external collar as well. And so you have basically these two internal and external calluses developing on the bone on either side. Now, once you actually get your callus formation, then it's time to convert that to bone, right? This is basically, we have a cartilaginous callus, and now we're going to ossify that. So this callus will basically be replaced by woven bone. Remember, the woven bone is the cheapest type of bone. Notice what you're doing. Every time you plug this fracture, you're basically starting off with the cheapest, and then you're upgrading to the next most expensive one, right? So the cheapest one of all is blood, hematoma, clotted blood. And then once you kind of get a little bit of cells involved there, your fibroblasts lay down the collagen, then you upgrade your plug into cartilage. That's a little bit better. And then once you establish your internal and external callus, then you convert your cartilage into the cheapest type of bone you can get a hold of, which is woven bone, right? And then, of course, woven bone is basically also spongy bone, which is the least structurally sound of the two bones. And then finally, at the very end, you get bone remodeling. This is basically where you come in and you replace that spongy bone. Your osteoclasts remove the spongy bone, and then your osteoblast basically will lay down the compact bone over time. And this is kind of where you sculpt your bone, finalize it, and kind of get it just right, just the way you like it. So that's kind of what it looks like. So here in step one, you can see you got a nice little break right there. So there's a complete fracture. So what happens then is as soon as it breaks, all these blood vessels rupture, you get blood spewing everywhere, and you start to get this big coagulated blood ball, the hematoma, that plugs this entire broken fractured area. And it has the effect of sort of keeping this periosteum sort of in place a little bit so that these cells of the periosteum can start doing their work. Notice it also captures here these little fragments of bone, whatever fragments of bone are there, to help out with the healing process. Then when you start to form the callus, you have your internal callus, which is going to be the big blob in the medullary cavity at this particular point. And so you're going to be laying down these cartilaginous fibers and, or excuse me, these collagen fibers and the cartilage. So you're going to be filling this entire region where your blood was. You remove the blood and you fill it, you replace it with cartilage. So now it's a little bit better. Notice what's happening here. The blood vessels are starting to grow back through that internal callus so that they can reestablish and reconnect. Then also at the same time, you can see that the osteoblasts that are basically on the surface of these bone cells and underneath the periosteum are starting to lay down bony matrix. So you can see the bony matrix starting to slowly fill in and starting to invade this cartilage. The external plug, which you can see out here on the outside of the bone, is doing the same thing. In this case, you have cartilage, which has been laid down, being slowly invaded by the osteoblasts of the periosteum as they slowly start to lay down new woven bone. Then after the callus stage, you get ossification of the callus, where the osteoblasts have basically replaced all of the cartilage with woven or spongy bone. And so this will do. Typically, you can probably put weight on this bone now. It's not the greatest in the world, so it's like, be careful. So over time, then what'll happen is your osteoclasts will come in here and they'll start to chew up this middle bone. They'll basically destroy that. And then they'll start to chew back the rest of this and it'll be replaced with compact bone. And so you restore then your bony matrix the way it was before. And so that's basically how your bones repair themselves. Okay, any questions on bone repair? Feeling good? So far, so good? Give me a thumbs up if it's yes. Otherwise, I'm talking to myself. Excellent. Okay, so one thing also to remember is from the callus stage, this is typically, oftentimes, somewhere around in this area is when the cast comes off. And remodeling, getting yourself back, this can take months. The remodeling months to almost a year, depending on the nature of the break and the nature of how much actually needed to be restored. So there's a bit of a process there. Okay, let's take a look at some of the homeostasis, the physiological aspects of bone. First of all, bone is one of the major organs for calcium homeostasis, and you need calcium for a lot of different things, including muscle contraction. This is where you store all your calcium. Okay, so ultimately, when you take a look at your blood calcium levels, you basically replenish your blood calcium by how much calcium is coming out of your bone or going into your bone. For instance, if you take in a lot of calcium, then generally speaking, what will happen is you'll activate your osteoblasts. And so when they do bone deposition, they're creating new bone. They're going to be taking the calcium, and then the calcium is going to be going into the bone itself, right? In the way of hydroxyapatite, right? As part of hydroxyapatite. Remember, that's the inorganic I don't know how to spell appetite. Okay. There, right? So you're packing your calcium in there in the form of hydroxyapatite when you're doing bone deposition. Then when you need to dump calcium into your bloodstream, you basically stick the osteoclast on it. It breaks down the bony matrix and it liberates the calcium, and that goes into your bloodstream, right? So if you take a look at calcium homeostasis, the natural rise and fall of calcium, typically when you're at a low calcium level, you get your osteoclast activity. It breaks down your bony matrix, releases that calcium into the bloodstream, and your calcium goes back up. At the top, you have your osteoblast activities. Basically, the osteoblast will deposit new bone, pack the calcium into the bone itself, and then your blood calcium levels go down. Now, when you take a look at calcium, some of the things that it does, first of all, it's important in muscle contraction. We're going to be taking a look at this in the muscle physiology chapter. It's also important in regulation of cardiac muscle contraction. So all muscles need calcium in order to contract. And also cellular molecules, especially like neurotransmitters, require calcium in order to operate, in order to work. And that's before you get to its function in hydroxyapatite. So calcium is a very, very important ion, a very important mineral in our physiology. And so we control it with a couple of hormones. First of all, there are three main hormones that control calcium. Parathyroid hormone, then there is calcitriol, which is a derivative of vitamin D3. We took a look at that a little bit. And now we're going to be taking a closer look at its physiological aspects. And then, of course, calcitonin as well. So let's take a look at each one of these. So parathyroid hormone basically is secreted by the parathyroid gland, which is essentially on top of the thyroid. So it's basically rests on top of your thyroid gland. And its job is to reduce calcium levels. Its job is, when you have reduced calcium levels, is to increase those calcium levels. So the direct effects of parathyroid hormone basically is, when you take a look at your homeostasis curve, I'm going to draw it again here. Typically, parathyroid hormone is acting at the troughs, at low calcium levels. Okay. And its job is to release more calcium into the bloodstream to send that back up. By the way, when you get into physiology like AMP2, this is a very common type of a curve. You see homeostasis all over the place in AMP2. And typically there are trough responses and peak responses, and they work together. So PTH, parathyroid hormone, is what I call a trough response. So its job is to increase calcium levels in the blood. And that does that by activating osteoclasts. And so when it does that, the osteoclasts are going to break down bony matrix. And so that's going to resorb that calcium, and the calcium is going to get released into the blood as the osteoclasts break down that bony matrix. Now, not only does it activate the osteoclasts by increasing the number of osteoclasts, but it also prevents the inhibition of osteoclast formation. So all those regulatory mechanisms that usually act to keep osteoclastic formation in an off state, PTH prevents that inhibition. The other thing that it also does is it stimulates the reabsorption of calcium from the urine in the kidney tubules. So basically, any calcium that you have being filtered to your kidneys, it triggers the kidneys to hang on to the calcium. Not to let that go. You don't want to flush that down the toilet if you need it. Now, Some of the indirect effects of PTH that's actively involved in, it will promote the production of calcitriol, which we mentioned before, is that vitamin D derivative hormone. This is the hormone that is necessary in the small intestines to increase calcium absorption. Remember, we said before, earlier in the chapter, that vitamin D is the vitamin that's necessary for as a co-absorbent of calcium in the intestines. Well, it's actually not vitamin D. Vitamin D is a precursor of the actual hormone, which is produced by the kidneys, and that's calcitriol. So calcitriol is basically the end product of vitamin D that is then necessary in order to absorb calcium in your digestive system. So really, the parathyroid hormone works on increasing calcium levels in your blood in 3 different ways. Number one, it stimulates the osteoclast to release and liberate already stored calcium from your bones and dump it into the bloodstream. That's the first one. The second one is the kidneys, as they're filtering out your blood, any calcium that happens to be in that blood that's being filtered is signaled to the kidneys to hang on to that. Bring that calcium out of the urine and back into the bloodstream. We need to hang on to it. That'll increase your blood calcium levels. And the last one is it stimulates the effect of the co-absorption of calcium digestionally. So if you happen to be consuming calcium, then it will activate a more efficient uptake of calcium as you're eating it, new calcium coming in. So those are 3 major mechanisms that the parathyroid hormone utilizes in order to get your calcium levels back up. Now then, so the way this works, and this is kind of like a little bit of, this is kind of a little deep in the woods, but this is just kind of to show you the receptor level of how this actually works, right? So the way parathyroid hormone works structurally is that on an osteoclastic cell and an osteoblastic cell, they have a receptor, an activator of a nuclear factor called kappa beta. It's a ligand that we call rankle, right? And so essentially, it has membrane-bound and soluble forms. And so rankle is a type of cytokine, which is the reason why we got interested in it. And so when we have a soluble form of rankle, which is this activator receptor of nuclear kappa beta, this triggers osteoclast formation. So rankle production itself that turns on osteoclast formation is important. And so it's actually regulated by what's called a Toll-like receptor. Now there's a bunch of receptors. It's part of cell signaling, how cells communicate and talk to each other on the surface of cells. And so there's different families of receptors out there. And the Toll-like receptors is one type of family of receptors. And so these tend to be similar to those receptors that we see in macrophages as they're going through their immune response in the body, in your immune system. So that's one of the things is, so it's regulated by this Toll-like receptor. Now what happens is rankle, which is the free ligand, which is just means a signaling molecule. That's all ligand means. It's a signaling molecule. This will bind to its receptor, which we call rank. And then what it'll do is it'll activate cells into osteoclasts. So it basically stimulates osteoclasts to begin the bone resorption. So it's kind of like an on switch. So where PTH comes into play is PTH will stimulate the synthesis and the secretion of this rankle ligand. And so this will be secreted by osteoblasts and osteocytes, and that'll increase your blood calcium levels. So essentially what you have is a signaling sort of a strategy where you have, let's say, the rank receptor, and you have the rankle ligand, which will basically come in and bind to this, and that'll tell this cell to basically start making osteoclasts and tell these osteoclasts to turn on. And then the stimulation or the production of that message is driven by the parathyroid hormone. So I know that probably gave you a really big headache. There's a lot of hardcore cell signaling in there. If a lot of that didn't stick, don't worry about it. There's a lot that goes into cell signaling, a lot of background in cell signaling that you have to get to in order to really kind of put it all together. But just suffice it to say that parathyroid hormone's job is to secrete the signal that essentially will turn on those osteoclasts. That's how it turns the osteoclasts on. Okay, so let's take a look at calcitriol and calcitonin. So calcitriol we already talked about, right? Because this is basically stimulating the absorption of calcium in the intestines, and it's derived from vitamin D3. So vitamin D will start in the skin, and then an intermediate will go to the liver, and then it'll go to the kidneys, and then it'll come out as calcitriol. So basically, skin in response to sunlight will make the first of the intermediates that will go to the liver. The liver then will make the second intermediate, which will then go to the kidneys, which will then turn it into calcitriol. And then from there, you'll be able to co-absorb calcium. Okay. Now, calcitonin is basically a hormone, and it controls blood calcium levels by lowering those blood calcium levels. So calcitonin is what I call a peak response, because what its job is to do is to basically inhibit osteoclastic activity and thereby favoring osteoblastic deposition. So if you take a look then at the completed homeostasis curve of calcium levels going up and down and up and down. So here's your calcium concentration. Then at the peak of calcitonin, that turns that curve downward by inhibiting osteoclastic activity and favoring osteoblastic deposition, taking the calcium out of the bloodstream. And then you have PTH at the trough response that basically uses those three mechanisms to dump calcium into the bloodstream, which is essentially liberating it with osteoclast activity from the bone, co-absorbing it with calcitriol stimulation, and then the third one, which is drawing a blank on that one. Oh yeah, the rankle piece. So stimulating the production of rankle so that you can turn on all those osteoclasts. Okay, so this is what it looks like. So here, basically, we're going to start off at number one. So here is your blood calcium homeostasis. Now, we're going to first of all move up in this direction. So our homeostasis is going to be disturbed. We're going to have a high calcium level, so we need to get rid of it. So this is your peak response. That's what we're going to start off with here. So as you have high calcium, basically receptors in your control centers will detect the high blood calcium, and they will secrete calcitonin. So actually calcitonin is being secreted by the thyroid, and that's actually an important point. Let me just make sure I make that point. So this is secreted by cells in your thyroid gland. So parathyroid hormone, which is also on the thyroid gland, is being produced by the parathyroid cells, and calcitonin is being produced by the thyroid cells. And so that's an important thing. So thyroid is going to be producing your calcitonin, which will then go to the effector tissue, and that'll inhibit the osteoclastic activity and slows down that bone breakdown, allowing the osteoblast to pack that calcium into bone deposition. And ultimately that should bring your calcium levels back down because you're putting it now into your bloodstream, or excuse me, into your bone instead of in your bloodstream. And so homeostasis is restored, and we're all happy. So then, when you take a look at the trough response, that's when your calcium levels get low. Then you're going to have receptors as well that are going to be telling the parathyroid cells that they need to secrete parathyroid hormone. And then parathyroid hormone will secrete and activate calcitriol to basically retain calcium in your urine. In addition to calcitriol, it will stimulate the reabsorption of that calcium in your kidneys and also osteoclastic breakdown. So you have digestive uptake, kidney reabsorption, and also osteoclastic release. Those are your three main responses. All three of those will act to increase your blood calcium levels, bringing it back up and restoring homeostasis. So then, what about this osteoporosis stuff, right? So osteoporosis simply means bone pores. That's basically what it means. It actually means bone pore, and then osis is the condition of. So it's a condition of bone pores. So it basically means you get porous bones or the loss of bony matrix. Now, generally speaking, when you lose the mass of your bones become weak, they deform, and they easily fracture, which is the reason why we are able to break bones much easier as we get older. A common sort of a thing as we get older that we always run into is that it's more likely that we're going to fall and fracture a hip. Generally speaking, fracturing your hip when you're younger is a pretty rare event. But as you get older, because of the weakening of your bones, those types of bones, which typically are compression fractures, are easily come by, especially if we fall. And so that's probably one of the major threats, I would say, probably as we get into old age. So is falling the wrong way and doing some sort of terrible damage to your body. Generally speaking, it's often more common in women, and that's because of menopause. So basically, that reproductive hormone cessation in menopause, when the hormones basically rewire, because as you start from puberty, remember you have three major hormones that are at work in the female body. Estrogen certainly is one of the big ones, but you also have luteinizing hormone and follicle stimulating hormone. All of those are basically working together in the monthly ovulation and the monthly follicle stimulation and follicle development of the female egg every month for as long as her fertile years last. And that usually will hit menopause in 40s, 50s, or whenever. But then when you hit menopause, the female body starts to rewire all of those hormone levels. And then that has a lot of direct consequences on the skeletal system, in particular in women. It tends to lead to a slippage, if you will, of bone deposition and bone density maintenance, which is the reason why in women it seems to be a little bit more aggressive. And that's because oftentimes you start to slip in that bone deposition piece. It's also sometimes because there's not enough calcium intake. Sometimes if you take calcium supplements that can help combat osteoporosis by continually feeding your system calcium so it can pack that extra calcium in the form of hydroxyapatite in those bones, strengthen those bones, get those bones stronger. And also, if you're not doing any exercise, the worst thing for your health that you can do as you get older is, especially as you start to hit menopause, and there is a thing called menopause. It's not as dramatic a shift in as males as it is in females, but to basically live a very sedentary life where you don't have any kind of weight-bearing exercise telling your bones that they need to be dense, they need to keep packing density into those bones to respond to stress lines, then you're basically signing yourself up for osteoporosis. It's going to be much more rapid in sedentary postmenopausal women who have little to no exercise regimen or exercise routine. And by exercise, we don't mean powerlifting, right? So you're not doing an Olympic power lift of 700 pounds over your head. You're simply doing weight-bearing exercise. So just take some relatively small weights, something like that, like just maybe a couple of 3 pounds or 5 pound weights, like ankle cuffs or arm cuffs, or in particular, and just walk, right? This is the reason why a lot of times seniors will like do the whole mall walk, or they'll walk around the neighborhood, and then their routine exercise is walking. And the reason for walking is because it is a load bearing exercise. It's communicating to your skeleton that it needs to maintain bone density. But at the same time, it's also low impact, because the last thing you want to do, as especially a postmenopausal or a postmenopausal individual, is to take on an exercise regimen that has high wear and tear, because your body cannot handle wear and tear the way it used to when you were in your 20s. Right? When you're in your 20s, you could bounce back from wear and tear quite easily, but not when you're in your 50s or 60s. So low impact exercises, which is the reason why a lot of times seniors will walk, or you'll see if you go to a rec center, especially rec centers that patronize the Silver Sneakers program of Medicare, you'll see a lot of seniors, a lot of older seniors, who will be doing a lot of different types of low impact treadmill exercises, or just low impact aerobic exercises and things like that. Swimming, water walking, a lot of times you'll see in pools, where instead of just swimming, you'll see the seniors will be walking around the pool and things of that. That's basically designed to be low impact, weight bearing exercises to communicate to your skeleton that it needs to maintain density, while at the same time avoiding unnecessary wear and tear that could help actually deteriorate your joints and your bones even worse. And so you have to be careful. So that was a little geriatric medicine there for you guys. Hope you guys enjoyed that one. But so ultimately, if you do get into that, you want to get early diagnosis, right? So the sooner you know that your bones are starting to lose density, the better. Because then you can start to bring on an active lifestyle, get that exercise routine going, do it every day, or however often the doctor thinks you should do it. Depends on your age and your situation. But do it routinely, right? So that's the important thing. And so we can treat osteoporosis with a couple of different types of medications. For instance, we have what's called bisphosphonates, are one type of medication that we have. I'm not going to get into the mechanism of each of these, but estrogen-like medications, estrogen replacement therapy is one of them. Antibiotics, even though you don't want to use antibiotics because you can abuse them and create antibiotic resistance, you don't want to do that. Also, calcitonin replacement, essentially kind of triggering that natural homeostatic mechanism to pack calcium into your bones. And so all those favor bone density development. So here's kind of how osteoporosis sort of affects the body at large. And each chapter has something like this in it, right? So from your osteoporosis, basically, if you're weakening your bones, you can also basically get to the point where you have muscular atrophy as well, because of reduced activity, because you can't walk because of your bone density issues. There can be a lot of nervous pain associated with that. And so that's another possible outcome. Endocrine, calcitonin is part of your thyroid gland that's being produced by your thyroid gland. And so this can also be treated or used to treat osteoporosis. If you break a bone, right, the increased blood flow is necessary for blood repair. So your cardiovascular feeds into that for bone breakage. The lymph and immune system, typically this will help you prevent infection. If you have to have, like, for instance, hip replacement surgery or something of like that nature. For the respiratory, so excessive smoking typically lowers your estrogen levels, so it kind of creates a pseudo-menopausal type of scenario, which will perpetuate osteoporosis. So typically nothing good comes from smoking. I mean, literally nothing good comes from smoking physiologically. It's the worst thing you can do for your health. In the digestive system, of course, you've got calcium coming in with response to vitamin D to help improve your calcium. In the reproductive system, decreased estrogen is associated with your reproductive menopausal shift. And of course, in the integument system, we have the production of vitamin D, which leads us to calcium reabsorption. So you can see how something like a skeletal situation like osteoporosis has touch and some sort of an impact on a lot of different types of systems. And this is kind of mostly true across AMP. Typically, systems are integrated with each other. They're not isolated from each other. So basically, if we kind of pull all that together, we have this sort of overall sort of aging of the skeletal system. Ready to get depressed? Let's get depressed. First of all, as you get older, your bony matrix decreases. Doesn't matter if you're menopausal or manopausal, your bony matrix decreases. Generally speaking, it will become a little more brittle because of the lack of collagen replacement. By the way, the degradation of connective tissue across the board is something that's happening as you age, right? So all of your joints, the connective tissue in your joints are degrading, so you can't replace your collagen quite as easily. You're more likely to sprain something. You're healing a lot slower. So a lot of things kind of add to this sort of general sort of degradation of collagen. That's typically one of the first things you see physiologically in your body. Aging, you'll notice, begins with your connective tissues. You notice your joints are not working the way they should have. Their tendons are hurting more because they're not being replaced. The collagen is not being replaced as well. And so if you're not replacing your collagen as efficiently, what that basically means is that's going to lead to more hydroxyapatite dominated bones, which is going to be brittle bones. But also you're going to start slipping in your hydroxyapatite as well, because you're not going to be doing calcium reabsorption quite as well. So your bone mass decreases. So typically you'll start to lose your spongy bone first, and then your compact will follow. And this will lead to an increased risk of bone fractures, like for instance, the broken hip idea, right? Because you're starting to lose your bone mass, that'll lead you to a greater risk of broken hips. And then the bone loss will sometimes cause deformity. You'll shrink, right? Because of compaction of the bones and the loss of mass. So you're not a lot. You're not going to lose like a foot of height. You'll probably lose a few inches perhaps. But this will also lead to pain in your joints and stiffness. So these are all issues that you hear older people complain about as they get older. Generally speaking, your posture will become stooped because of the inability of the frame, your bone mass, to hold up your body. You'll start to lose your teeth. So because typically you'll start to get, the wear away of the alveolar margins. Where are the alveolar margins? It's basically the lines of your mandible and your maxilla, where the roots of your teeth are embedded in the bone of your maxilla and your mandible. So as those alveolar margins start to erode, bone mass wise, then that starts to create a loosening of the root system of the teeth in the actual mandible and the maxillal bone, and then they'll start to come loose, essentially. And then also you have your articular cartilage, which will start to wear down. Eventually you'll wear through it because the replacement rate decreases, and ultimately that leads to arthritis. So arthritis is basically a deterioration type of disorder that we experience typically in old age, because we've put thousands, perhaps millions and millions of steps on those joints. The knee joints in particular are the ones that we feel oftentimes. So joints that we use a lot. Okay. Now, how many of you guys are good in looking forward to your next birthday, right? Okay. Now let me go ahead and if I can't open up the next. Oops. Okay. So Ashley, that is a good point. So basically the lecture exam will cover up to, it'll be 1, 4, and 6. So pretty much everything. So the chapter that I'm going to do now, and I'm going to do that in the background while we kind of talk about the exam. So while I'm kind of doing that, I'm just going to go ahead and take my screen share off because, I mean, there's no need for you guys to see me flipping around Canvas. I'm sure you guys do that more than enough. So in terms of your format that you're talking about of the exam, it has been written. It's got an 80-20 split for the lecture exam. And so the 80-20 split basically means it's going to be 80% of it is going to be multiple choice, and then 20% is going to be written. And so that's going to be okay, I'm gonna log in here. So that's going to be the format. Now the written is going to be, some of it's going to be short essay, and some of it's going to be matching. So it's going to be like, there's going to be some definitional stuff, certainly for the matching, kind of an idea. And so that's going to be a piece of it as well. Was there anything specific that you were thinking of in terms of format?
What like specific things in each chapter do you think we should more focus on?
So 1 and 4 are, well, 4 is pretty obvious, right? I mean, pretty much all tissues. And the nice thing about 4 is it heavily overlaps with labs. So kind of studying for lecture 4 and studying for the lab exam kind of go hand in hand. So like studying for one is also studying for the other. So it's kind of a good synergy there with that one. For the chapter 1, it's going to be like all of those introductory ideas. There was several different introductory ideas that came into there, from just the basic definitions of anatomy and physiology, regions of the body, things of that nature, regulation, homeostasis. So there was a lot of different introductory types of ideas that were coming in there that we wanted to take, that you want to take a look at, make sure you have a good foundation there, because a lot of those do kind of feed into the rest of anatomy and physiology. Does that make sense?
Yes, thank you.
Does anybody have any other questions about formats or anything of that nature?
How many questions are there on the sorry, that was my dog. How many questions are there?
So there is 63 questions. The first 50 are multiple choice and Scantron related. So you want to make sure you bring a pencil. And 51 through 63 are kind of the short essay and the matching and stuff like that. That make sense?
Yes. And what about the lab exam? How many questions?
So the lab exam will probably have, I'd say, probably about 50 questions. It'll be a 50-point exam. Generally, what I'm shooting for is 25 stations, 2 questions apiece. Some of that's just a general guide. A lot of times with the lab exams, I have to pivot at the last second as I'm setting it up because the materials that I have in my mind that I want to set up, I either don't have access to or they're not available. Like some other instructors using them and I can't get a hold of them. And so I have to do a quick pivot. So it'll be some variation of that theme. But that's the ideal. The ideal lab exam is 25 stations, 2 questions apiece.
And those are all essay questions?
Those are all, well, not essay questions. They're just like, they're fill in. So obviously, like if I point to a structure and I say, you know, what is the name of this bony landmark or what is this structure? Then it's just basically like a little small space where you could put something like styloid process or lateral malleolus or something like that, right? So it's not really an essay, it's just, you know, a name or a term. That's basically what it is.
Does the exam take place during the lecture time?
So the lab exam we will be doing at 5 because it'll be set up in the room. And we won't be able to be in the room without all the lab exam stuff set up in there, right? So the idea is we'll start the exam around 5. Now, if there's like some setup stuff that I'm still having to do, it might start a little bit later, depending on if there's any stations that I need to tweak or something of that nature. But generally speaking, that's what we're going for, is we're going for 5. And then what'll happen is we'll get ourselves settled in and sort of ready to go. And then once we're ready to go, then what I'll do is I will time everybody through each station for 1:30 per station. And then once we finish all that, like complete our circuit, then what I will do is I will allow you guys to revisit stations that you feel like you want to take, you know, a second look at or whatever. And you can do that until you're content with what you have. And then after we do the timed piece, though, before you start the free visit, I will probably give you your lecture exam so that you'll have both of them there with you and you can kind of go back and forth and you can work on them as you wish. And then you can turn them both into me at the same time. And then you'll have probably plenty of time to work on both of those. That's usually how I do it. It's kind of a little free form that way, but it kind of gives you a little bit of room and flexibility. And sometimes I've noticed in the past that a lot of times students actually like kind of having both exams in their hands. They can kind of go back and forth between the two. It kind of helps them to sort of, you know, think about one exam and then sort of take a break from that one and work on the other and kind of go back and forth. It kind of helps them to sort of do a little bit of stress management sometimes.
So we have a lab exam and a lecture exam on Tuesday?
Correct.
Okay, and they're each 50 questions?
No. The lab exam will be around 50 questions. The lecture exam has 63.
Okay. Sorry, I'm writing this stuff down.
Okay.
And then the lab exam, is the difference just that it's more about identifying on the actual skeleton stuff in the lab?
Yeah, so the lab exam is going to be all just lab-based stuff. Like whatever we did in lab, that's what the lab exam is going to be. So it's
Okay,
going to focus on our activities in the lab.
okay. What was I gonna say? And for the lab, so I was, actually, I'll ask you at the end of class, but, my other question is, will it be a problem if I'm running late to the 5 o'clock time? Like if I get there at 5:30?
I mean, you'll still have it, right? Because I mean, what'll happen is we'll probably have been a half an hour into the timed portion of the lab exam. So if you're running a little bit late, what I'll do is I'll give you the answer sheet and you will just have to dive in like at whatever spot you can, and then kind of finish that out. And then so you'll end up having to sort of pick the rest of it up on the free visit part after the
Okay.
fact.
Thank you.
Yep.
So for the lecture exam, since it's 63 questions, does that mean that there might be a couple extra credit type questions in there?
Certainly that's always a possibility. I tend to embed my extra credit into the exams themselves.
Okay.
Any other questions?
Yes, can you quickly just go over the material that will be covered in the lab exam? During my time in lab, a lot of it was very much like kind of just reviewing the lectures and getting familiar with the information of the lecture. So I'd just love to get an idea of,
So the lab exam is going to be focused on the lab activities we did. The first lab that we did was histology. And so we had our little sheet, and actually, let me toggle to that and open my screen here because I'm there. So we had histology, and we had our little cheat sheet of all the things that we need to be able to identify from our slides. So this document, which is under modules, is basically where I got it. Week 1 was histology. And so the things that I'm going to be looking at is basically all of these things that we have under identify this, identify that. So those are the things that have basically been guiding us in terms of what we need to be able to identify. So there'll be microscopes on the exam. And then of all the different tissues. And then the last several weeks, we've been working on the skeleton. And so this is our list of things that we need to know in terms of structure. There'll be models for the most part in front of you for skull and vertebra and so forth of all the bones we've been looking at for both axial and appendicular skeleton, both the bone itself and of course the landmarks on the bone, which are things like, for instance, if you take a look at the femur, the head of the femur, the greater and lesser trochanters, the lateral medial condyles, and so forth. And so that's basically what's going to be on the lab exam.
okay, thank you so much.
Yep. Any other questions? Okay, so that's about our time. One of the things I'm going to be doing, I'll do this in our schedule, but our schedule basically has chapter 7 coming up here next. Probably, and all that is basically to take a look at chapter 7. I encourage you to take a look at chapter 7. It's essentially what you guys have been doing in lab for the last 3 weeks, right? So it's literally the exact same thing that you see in Marieb, and it's basically the exact same thing. So rather than recapitulating all of that bone anatomy, which we're going to be tested on Tuesday, what I'm going to do on Thursday is I'm going to, rather than going into the anatomy all over again of the skeletal system, because we'll have already been tested on it and it'll be basically pointless, I'm going to start up with chapter 8, which is going to be joints. Is that okay? Okay, so Tuesday, lecture and lab exam. And on Thursday, we'll start off chapter 8 with joints. And then we will not reproduce or double dip on skeletal anatomy because you guys are already getting pretty glassy eyed about skeletal anatomy. So, okay, wait. Melissa, are you meaning like a smart book assignment? Do you mean?
Yeah, that's what I mean.
Absolutely. I can actually do that right now because I got McGraw Hill up. So it'll be just like the other assignments, like a 10-point assignment. And then I'll set that up and I'll give you guys a little bit of time to do that. And then that way, that's a really good idea, Melissa. Thank you for bringing that up. That'll be a really good way for you guys also to collect points that could help go toward kind of buffering whatever happens on the lab exam. So that's a really good idea. I'll go set that up right now. Okay, that's it. Then we're all good. We'll see you on Tuesday.